So into today's session then, we've got four absolutely fantastic speakers for you. We have Farzana Hussain, who's a GP at Project Surgery and a clinical director in a PCN in Newham Central, and also in 2019 was crowned GP of the Year, and we've got her Twitter account there. She's a committed and probably addicted, I would say, tweeterer. We've got Mike Emery, who is the digital lead in Herefordshire and Worcestershire, and who I know is very thoughtful about the use of digital technologies and its applications to better care in that area. We have Reena Sangar, who's the global head of digital and connected health at our partners Ipsos MORI, and who will bring a broad perspective, research perspective, to the topic today. And we have Andi Orlowski, who is director of the Health Economics Unit, a sister team of ours, and who I know is borderline obsessed with data and the use of algorithms and the implications of that. I just wanted to say one or two words really, just to set the scene very briefly, and also to, I think, begin by acknowledging a debt we owe to Yuval Noah Harari, who particularly in his book Homo Deus, has written very interesting, provocative thoughts about AI and the way it might evolve and what that might mean for human decision making. And he wrote, I think in 2015, and he was speculating about the future. And where are we now? You know, at the weekend, I listened to a podcast that was run by a human interviewer who was interviewing an AI. And the questions and the responses were driven by an AI. It was astonishing. And then my kids, of course, can't open the door without asking Alexa what to do about it. So already we're starting to see the role of AI in our lives. But Harari asks us to speculate about where this might go and about what might happen as the power of AI increases, drawing on the increasing quality and quantity of data available to us. And he thinks about AIs as becoming ever more powerful and impinging ever more in human decision making. And if we thought about that in relation to health and social care, we might think about people or patients with AIs that are better able to monitor and maybe even predict problems that are coming their way, that are more able to choose between treatment options and what's more likely to be better for them, given their characteristics and given their behaviours, and also that is less prone to self-delusion than we as individuals are, and that might have a clearer sense than we have as to what treatments we're more likely to stick with or to refuse over time. And if we thought about it from the clinician perspective, AIs might offer an opportunity to provide access to care in a very different way, particularly advice and guidance. AI has already been used in diagnosis and also perhaps again in the selection of treatment options. And these things might become more attractive given the chronic workforce shortages that we seem to be facing. So there's a whole world of opportunity created by technological advance and by AI. But as with every technological advance, there must be downsides. If there are these upsides, there must be shadows to it as well. And we might think about the different shadows cast by AI in terms of what is lost by the human role in decision making. So humans can make decisions that are necessarily fallible and might be less rational and less efficient than AIs, but humans can explain why they've made decisions, and they can be accountable for decisions they make in a way that AIs can't. And we might also think about degrading human power and degrading human capabilities as AI starts to impinge on decision making that might be ethical in nature, or that might necessarily be addressing uncertainties in future. Do we lose our ability to do that as we draw on AI? Have we lost our ability to navigate given what Google Maps can do for us? And what's the cost then in human terms if we take advantage of those opportunities? What I'm going to do then is ask our four speakers to say something. They'll each speak for, I've briefed them, so you can all help me hold them to this, a little bit less than 10 minutes perhaps, just in broad terms to sketch out their thoughts on the topic. I'll invite each one of them in turn, but as I say, if you could put questions in the chat box, then I'll also gather questions up and I'll put them to panel members. I've tried to do this sort of alphabetically. Andy, you must lose this every single time on that system. So can I hand over to you if you'd like to begin by outlining your thoughts, please?
Thank you ever so much, Fraser. And you could go by surname, and then I would have I'd be able to dodge the bullet. But thank you ever so much for joining me and the rest of the gang, Mike, Farzana, and Reena today to talk about AI. And as Fraser has mentioned, clearly one of the reasons he wanted me to go first, because I'm the nerd for this. Yes, I'm the one who was the few people who's actually voting and rooting for Hal in 2001. Dave was an idiot. He needed to go out of that airlock. But there are some great things that AI can do for us today. AI is awesome. And by AI, I think the vast majority of us are actually talking about the machine learning algorithms that we put behind data, and particularly big data, to better understand what's going on. So this includes, you know, some of the exciting stuff that we're doing to build predictive algorithms, but also includes some of the kind of more mundane stuff that we do. So as you know, trusts are huge organizations, multi-billion-pound organizations. And again, the performance and operation monitoring of those trusts can be done by machine learning. We can automate many of those skills and many of those presentations and slide decks. We know that sometimes aren't watched as much as often as we would hope, but are used to keep the organization flowing. So we can release capacity by using AI and machine learning tools. We can evaluate new intervention and care pathways, and there are some amazing people, not just at the health economics unit, but in other sister teams who are also working with having a look at, you know, how we evaluate AI in the bigger world. So just to say that there are tools like NHSX, where they're spending £300 million on AI technologies, you have the opportunity to look at those too. So a great way of doing that. There's opportunities to improve the quality and safety and the system efficiency, so we can drive value. And I know there's sessions later on that look about how we drive value in integrated care systems. And one of the amazing things that we can do with AI, and then this may be controversial, is we can uncover health inequalities with AI. Yes, I know there are problems with data, and we'll come to that in a second, but AI can help us improve and uncover health inequalities and direct resources where it's needed. And of course, to help direct care for individuals and populations. There are amazing trusts out there today that are using AI simply for waiting room space. So at Chase Farm, you may know that you can walk into Chase Farm and it already monitors how much room, how many seats are being taken in different parts of the hospital, and it diverts you and tells you to sit in another waiting room so you're not overcrowded and you're not too much, let's say, and we can reduce the risks behind that. So AI is brilliant, but of course, AI needs data. So the great big thing about machine learning algorithms and the work that we can do is that we can use it on integrated data sets. There are amazing integrated data sets that are already out there. So if you look at the work that's been done by Mark Farr and the kernel, which has primary care, secondary care, social care, community care, fire and rescue, mental health, and you can overlay pollution and others. So these great big data sets that have billions of rows of data, you can't go through them, you know, in the old-fashioned way of us, you know, I say old-fashioned, the way that I was taught at school, yes, by using regression and those approaches. What we have to do is to be able to use machine learning algorithms to better understand and dig through this data much more quickly. And so there are integrated data sets out there. There are places that are putting together those integrated data sets now. And by having that richer data, we can better understand the individuals in our population, and therefore be more accurate, be better prepared to offer them a solution that works for them. And so we're working right now with NHS England, building 2 predictive algorithms for the nation. One looking at ambulatory care sensitive conditions and where we can then target resources and interventions afterwards, and one specifically for COPD. And these are not just using the kind of tried and trusted routes that we've done before with PAR and combined and those predictive models, but what we're using is causal inference and machine learning to be able to better understand what causes those interactions, the unwanted interactions, be it in hospital or an outcome, and then to be able to target an intervention for those patients, hopefully addressing some of the behavioural and social needs as well as just the medical needs. So exciting stuff. But of course, with data, we know there comes, and with machine learning, there comes a whole load of potential issues. So the real world patterns of health inequality and discrimination. So there's unequal access to resource allocation. We know that discriminatory health processes and bias on clinical decision making. And this is also reflected in the data sets. Yeah, so because of the way we treat people and how we manage people and the access, it changed it. We know there's sampling biases and lack of representation in the data sets, and and there's patterns of bias and discrimination baked into data distributions. So these wonderful data sets and these integrated data sets that we have, if we start to build algorithms using them, are we going to be baking in some of the inequalities that we're trying to address? There's biased AI design and deployment practices. How we put together the agenda for what we're trying to, what are our priorities, often based off of data and how we manage that data. And of course, that data is biased for certain populations. And there's, are we building algorithms that, because of there's less data for certain populations, they work very, very well. So not only do we set priorities on a certain population, we then build algorithms that target and help manage a certain population above and beyond others. And then how do we deploy them? Do rich areas have a greater access to integrated data where there's, we say there's less deprivation, where we can use those tools? And of course, how we use AI. So hazardous and discriminatory repurposing of AI. So people are very, very worried about things like track and trace and people following your phone around, and how we include people to be able to manage that. Exacerbating global health inequalities by having these gaps between rich and poor by using these techniques. And Fraser mentioned Alexa. How many of us have Alexas in our rooms or in every room in the house? And how many people would have access to some of the opportunities with Alexa Health, and to be able to kind of, if we could link Alexa to your GP to ask for some of these questions. So there are issues not only with the world, but with data, design, and the use of these AI algorithms. But as you might suspect, I have great hope for this, because as Peter alluded to at the beginning, one of the big ways that we can tackle this is with a capable professional workforce. And that's the one thing that NHS has. And I think that we forget quite how many amazing people that we have in the NHS who can deal with this. And I've got one slide to share, one slide which I'll try to now, and I promise we'll go back. Here we go. So hopefully you can see what it should look like, a veritable boy band meets girl band face-off. And here you have some of the amazing analysts, computer scientists, data scientists, and big data say scientists that we have just in our unit alone. And so if you imagine just the capability we have with over 20 masters between them, over 6 PhDs, this is one team dedicated for advanced analytics in the NHS. So I just want to say that this capability is all around the NHS, not just in our team. Of course, we're special at the Health Economics Unit, of course we are, but we know that there are very, very capable teams out there. So just to say that those biases are there. There's a wonderful paper written by Ben Goldegg et al. About the 21st century of data biases and how and analytics, and how analysts can play a really key role in this. And so because the analysts understand some of these data biases, by having local analysts who understand the data, they can do some diligent bias and self-assessment regimens. They can have a look at the data to see where the bias lands. There are interoperable models on how we manage, let's say, and how we manage that baked-in bias in the data. We can assess sampling bias through knowledge of the target population using your local analysts. This is why the decision support unit is so important, I think, for the Midlands. By having those skills built into the Midlands, we understand those populations, and we can then better understand the biases. When we start to build algorithms and we start to employ them and send them out, are we being inclusive of the community? And are we being community-led and have an interdisciplinary deliberation, with our populations? Are we being transparent about our work? And that's one thing that has always been drummed into me at MLCSU, is about making sure our code is open and that people can see what we've done and why we're doing it. If you've paid for it once, it's free for everyone. So that's a great point, but it's also making sure that our work can be scrutinized by others. We make sure that we're inclusive when we're using technologies to make sure everyone can use them, and researchers can make sure that they deal with resource and capability gaps by flexing our skills across the patch. So yes, AI can do some amazing things. Yes, there are problems with the data, but we do need big integrated data sets to make the most of machine learning and to give the best for our patients. I really truly believe this. If we're going to do integrated care systems, if we're going to tackle wider determinants, we have to go beyond just health data. But we have an amazing, capable workforce across the NHS, across the decision support unit, across our region, who can help manage this. And because they understand this data and because they understand the issues with this data, they're dealing with it from the start. But thank you, Fraser.
No, thank you, Andy. That was spot on, the allotted 10 minutes as well. I don't think I've ever seen you restrain yourself in that way. The feeling I took from you is of general optimism and positivity, but also not blindly. I mean, I was hearing all sorts of downside in what you were saying, and the need to be mindful of that, and also some solutions that you were suggesting, particularly use of the workforce and combining different inputs. We've had some questions already starting to emerge in the chat, and I'll start gathering together. We've also had a request from Shirley Berry that if people would stop saying Alexa, that would be really helpful, because apparently hers is going off every time someone says Alexa. So we should definitely stop saying Alexa. If Farzana, if I could hand over to you now, and if you could remember to not say Alexa in your 10 minutes, that would be great.
Thank you. I'll try not to giggle all the way through. I'm having so much fun listening. So thanks for having me. So when Fraser, you asked me to do this, I thought, oh crikey, I don't know anything about AI. I don't know why he's asked me to do this. And then actually I was thinking, since we had a chat last Friday, didn't we? And I think as a GP working in, East London, I think probably this is more pertinent than ever. I mean, you may have heard a few little stories at the moment going around the country about, face-to-face and the importance of face-to-face and how that is so much more superior than any other mode of consultation. And just listening to Andy, it got me thinking about, what is AI and what things are we actually already using. So me as a GP working in a smallish practice, 5,000 patients, been here for 18 years, there is nothing more valuable to me than the doctor-patient relationship, what we always talk about, a sort of almost a sacred relationship, continuity, offering cradle to grave care, which I think small practices can still do. And so I wondered if I had a bit of a personal bias. Andy's talking about baked-in bias in data, but did I have a human bias about somehow AI is going to erode that, and what's going to happen to my beautiful relationship with my patient that only I can think about, because of course general practice is an art, it's not a science. And then I thought about, well, when I trained back in 1997, I qualified as a doctor, and we used to take great pleasure in being able to identify those Korotkov sounds when we were measuring the blood pressure, and you know when they're beginning and you know when they're finishing, and there was a great pride in being able to check a blood pressure. And of course, they were all a bit different, weren't they? Me taking them as a medical student, taking a blood pressure, was quite different to somebody who was taking a blood pressure every single day. So I wonder how reliable was the actual measurement that we're taking. Fast forward 15, 20 years, and actually I don't take any blood pressures. We have not only electronic blood pressure machines where my healthcare assistant does that, but actually since the pandemic's hit and we have been very concerned about COVID risk, my area in Newham was very fortunate that we all got bought from our CCG self-service blood pressure monitors. So now what that has done is that it sits in our porch. We're open 8 till 6:30, and anybody that wants to have a blood pressure check doesn't need to come in on a really rigid appointment time. They can actually swing by any time between 8 and 6:30. And what have been the advantages of this? Well, you know, my working ladies who need a blood pressure check every 6 months just to have the contraceptive pill, you know, what a drag to take a morning off work just to get your contraceptive pill. So they can now swing by and get that anytime, and they're very happy. Andy was talking a bit about health inequalities, and I know we've got a lot of sessions in the festival about it. And today we've had a paper published this morning by Public Policy Projects and Michael Marmot, a huge paper about health inequalities. Very important to me, working in an area that's got a high financial deprivation and 74% BAME in Newham. But we know that actually we still don't diagnose enough hypertension in the country. So having people just be able to stick their arm into something and us being able to look at that result. Because I think when we talk about artificial intelligence and we talk about health inequalities, I immediately think, and I'm sure this is my bias, is that that more artificial intelligence will by definition equal a wider gap in health inequalities, and that's something that's very much a narrative at the moment with doing online consultations or digital consultations. Can these people understand it? Can they understand symptom checkers? Are they putting in the right information? So it was really interesting that Andy was actually challenging my thinking and thinking that actually this could reduce that gap. And certainly some of the things we're doing in practice, you know, 5 years ago, if you were in my practice, you'd be getting an appointment to have your high blood pressure check, where you might be at work or you might be busy with your kids or you might just be having a lie-in. Then we would tell you off for not coming for your blood pressure check, you naughty person. Then we would invite you another 2 times, and then we would tick our box and say, we tried, they didn't come. And then sadly, if you had a heart attack or a stroke later, we would feel that we'd done our bit. So just by making it so much more flexible now, 8 till 6:30 weekdays, you fly in whenever you want to. So I think for me, the future is for me as a GP to maybe challenge my own biases, to widen my own thinking. I will, to the day I die, defend the GP-patient relationship. I'm not saying doctor-patient relationship, because I do believe that we have a huge privilege as GPs being able to see people not for episodic bits of care, but throughout their whole lives if they choose to stay registered with us, and their families, and all that data that we have in our heads, that soft data about whose mum died and is that why they might have this particular condition this morning. But do we have enough data? And now that we are in general practice part of primary care networks, and we're more than 2 years old now, and Andy again alluded to the fact about social determinants of health, and actually apart from your medical conditions, where you live and whether you have air pollution. I'm standing here in Stratford in Newham today, and we sadly have the highest air pollution rates in the country. We have some of the highest homelessness rates in the country, and we have some of the highest child poverty rates in the country. So one of my kiddies coming in with asthma, if they're living in damp conditions in temporary accommodation and they're likely to be made homeless, they are not going to get the best start in life, and my little inhalers aren't going to be able to solve all that for them. So I think that need for data is even more important now than it ever has been, if we're really going to bridge that health inequalities gap and think about a well NHS rather than reactive treating the sick in the NHS, which is perhaps what the idea was in 1948, but we're getting older, we're moving forward. So I think for me, I'm really enjoying being here because it's challenging a lot of my thinking. And I think there is definitely a place for AI. I think I'd like to learn more about what we mean by AI. My particular involvement with it is, I'd say, quite small, but probably bigger than I think. Symptom checkers really do help people if they can have the confidence to use them, and if their doctors and healthcare professionals can trust them to use them. We can, I've given a good example that we've had about, blood pressure. And then the other bits, Andy talked about workforce, but stuff that we in general practice would call like back office. Andy mentioned a hospital, but I spend a lot of my time, as on taxpayers' money, earning pretty well to transcribe hospital letters that say Fraser needs 10 milligrams of amlodipine for his high blood pressure. We've changed it from 5 milligrams. And we think we're doing a great job, and the taxpayer's paying me a lot of money, but sometimes I'm tired doing that because I've seen 70 zillion patients before then, and I'm doing it in my lunch break with no lunch, and I can make mistakes, and then Fraser might not get the right medication. And I think that we already have the ability with machine learning to be able to transcribe that information that would be safer. So I'd like to see some of that come into action, because we've got 7,000 general practices in the country and a lot of hospitals in the country. So I think there's stuff that we could do where the technology is already available. So I want to say thank you to you, Fraser, and the 113 of us who have joined on a busy Monday morning, because I'm hoping that this will improve patient care. And if we do it thoughtfully and we do it with our patients, I think it will actually narrow the health inequalities gap. Thank you.
Oh, look, thank you ever so much, Farzana. You have changed the way I've been thinking about this as well, and perhaps I would have written a different introduction if I'd heard you speak first. I really like the way that you've drawn on what Andy was saying and have started to press into the GP and patient relationship there. And I like the way also that you've started, with an incredible degree of honesty perhaps, started to say, well, yes, machines and algorithms may contain bias and may contain flaws in decision making, but so too do humans. And particularly tired humans, and I can't remember the exact number, but 40 zillion or something patients, may lead your decision making to be slightly degraded in the face of the next one or the next task. And so, what therefore could AI do to take off some of the load of the labour that you're performing that perhaps you don't need to be performing as well? So I really enjoyed listening to you. And also you with that, again, unwittingly perhaps have teed up Mike beautifully, because I know that, Mike, you're pressing into examples of that type of thing where we can harness technology to better improve care. So can I hand on to you then, Mike, and if you could outline your thoughts for 10 minutes or so. You'll be improved by coming off mute.
I do that every time. It seems to be the penance of someone leading on digital that I'm unable to operate Zoom. It's an absolute privilege to be here this morning, and great to talk to you. I'm just going to spend the next few moments reflecting on a couple of actual real-world examples where we're using machine learning and AI currently, particularly in response to some of the challenges we're facing around patient waiting lists. Few reflections from me on AI and some of the challenges of sort of making it real, if you like, and how we're engaging some of the clinicians, and then just a few final thoughts around maybe possibly some of the limitations or some of the things we've got to think about going forward. I should broadly say, much like Andy, I am an enthusiast for AI and algorithms. I think the time is now. I think what we've struggled for the last several years in the NHS, we have masses of data and sometimes we can't see the wood from the trees. And a lot of that is, how can we look at that big data and use it to improve some of our care models and some of the outcomes we want to deliver. So I think it really can help with better decision making and really, help a lot of the clinicians with some of the heavy lifting. In Hereford and Worcester, for example, what we've been doing is looking at how we can apply some of those machine learning techniques to our patient waiting list to help, if you like, almost prioritize those on the list on the backlog. We're using a tool that will look at some of the data and read the data. And this is more than just sort of word search. It's natural process language, looking through thousands of records potentially to assist with that prioritization, but also to potentially assist with data quality as well. Where there may be errors in data quality, it can also look at the coding. Alongside that, we're looking at using automated callers and chatbots to talk to the patient and to understand their situation if it's changed. Now, interestingly, we've had lots of conversations locally with clinicians, patient groups and Health Watch around, how much do people want to be talking to human beings and what their reaction to this is. In the main, actually, people have actually gone with it, and there haven't been a huge amount of negativity towards the use of things like chatbots and the use of AI to search records. And it is improving our data quality. It has improved our response rates, and it's actually, from a economic point of view, saved the distribution of thousands of letters to lots of patients and letters getting lost on the way. So broadly, it's been positive, but there have been some concerns that we've been thinking through. And we talk about health inequalities. People have raised the issue that not everybody has access to a phone. Not everybody clearly understands a particular language. How do we cater for that? So we are building that into our learning and taking that forward. All things we've got to consider in the round. Interestingly, though, we've had a lot of positivity around, we can run that chatbot at certain times of the day. So the calls sometimes are in the evening. That helps people. And actually, when we're talking about connecting with different groups, the fact that we discover that actually there is a significant cohort, for example, homeless people that do have phones and smartphones, and actually they wouldn't be able to receive a letter, and so they can be contacted by phone or automated caller. So lots we're using, and all this information then informs our prioritization. However, I do think there are some things that we've faced, sometimes trying to explain what the AI and the algorithm is doing around the patient waiting list and prioritization list to a lot of clinicians. And I mean this in the nicest way, that unless you're an Andy, sometimes when you get into the detailed terminology and the different analysis, if you're talking to a frontline clinician, someone in the PCN, sometimes we've got people that really do grasp, but other people going, you're presenting all these tables and graphs and what the AIs do. Can you just, I haven't got time to go into detailed regression analysis, inference analysis. How do you explain to that work through with me at PCN level? So sometimes I think, we've got to understand the audience we're dealing with when we're talking about the AI. And I think we also need to be very open and honest and transparent about how we're operating and the information we're using. I think there are some interesting papers. There is a guide to using AI in the public sector, which talks about the importance of things like data quality, fairness, and being very sure about the accountability of the use of that data. And one thing I think we need to bear in mind that we often forget about is some of the legal aspects in the UK GDPR. There's a whole thing in there around the use of automation for decision making, and there are some limitations that we need to be very mindful of when we're aware of that. And then just a few other thoughts. I think if we are developing algorithms, we need to make sure that it is adding value. It's very much integrated into a clinical workflow. That's something that a lot of our clinicians have said to me. Don't try and add it on. We've got to see the benefits. I think the use of big data sets is really key. And I think with the emergence of things like shared care records that are appearing all over the country, that's going to be a big benefit where we're bringing primary and secondary care data together. And I also think we've got to take into account costs. We could spend an absolute fortune sometimes on AI models, but actually a simple analytical tool or just common sense may give the same answer. So let's just sort of think through occasionally what's the cost benefit analysis. And then I just want to end with one little story really around sometimes there is always the risk with AI that if there's a flaw at the start or a particular assumption, you can end up only by exacerbating that flaw at the risk. And one little story, I was at my daughter's party a few years ago and with her friends, and her eldest sister was there, my daughter who's autistic, and we're playing pin the tail on the donkey. And my younger daughter and her friends had worked out the number of steps up to the donkey, and they were pinning it in with a blindfold on, and were working out as they went up that if they could feel where the last little hole was, if they moved slightly to one side, they could get nearer to the spot. And at the end of 5 or 6 goes, there was a little cluster of everybody around, about 2 inches to where the tail of the donkey was. My eldest daughter, who's autistic, looked at this and thought this was a silly game, whipped off a blindfold, walked straight up and just pinned the tail on the donkey. So what I'm trying to say about this, there is always the risk that if the AI, human ingenuity still is needed and the ability to think a little bit differently. What AI hasn't got is imagination or that wider thinking around neurodiversity and looking at things in a different way. So I end that is, don't worry, human beings, AI can help us hugely with the heavy lifting, but there is an element of human ingenuity and the way we think about things we mustn't lose.
Thank you, Mike. That's great. I love the spirited defense of the human
Yeah.
at the end of that. I also really like the way that you were describing the ways in which you've thought through different potential uses. So, for example, addressing backlogs, and also the way in which you've engaged, in a sense, with the sort of potential users of it. So, GPs and clinicians in the potential use of it, and also your engagement with the population. And I love the question that you went at them with, which was something like, who still wants to speak to a human? I thought that was great. I think you've touched on some themes that I'm thinking Reena may well pick up on in her 10 minutes. So can I hand over, Reena, to you to outline your thoughts on the topic, and then we'll ask questions of each other.
Yeah, sure. Hi, everyone. Thank you for having me. I'm Reena Sangar. I work at Ipsos, which is a global market research and insight agency, but I started my career in the NHS. I always feel quite charmed when I come to events like this. I worked as a primary care mental health worker, training in CBT before pivoting my career into research. And since 2015, I've been purely working on digital health, mainly in the private sector, and helping things like Freestyle Libre come to market would be one example if you work in diabetes in terms of remote monitoring. And I don't know, with artificial intelligence, I had the pleasure of actually listening to everybody, so I kind of can bring my thoughts together and hopefully make it a bit different. My big thing with artificial intelligence is infrastructure and data access and data privacy. There's a lot of things that have to be worked out before we get to an algorithm that we still have a lot of challenges with. I run a study called Digital Doctor. It's been running since 2015. Data is available online if anyone here is in research and cares. It's a study across multi-markets, so 22 countries, and it's all with GPs, so all with primary care physicians from around the world. And one of the metrics we've been measuring since 2015 is the perception of artificial intelligence, and will it actually help and enable you as a clinician, or in fact do the opposite. And it's been interesting to track. So since 2015 to now, the level of anxiety has come down significantly across the world from clinicians around the role of AI. The excitement has been fairly tempered throughout, but is kind of edging upwards. And there's a belief across doctors that this is going to be influencing the future of health. That's a positive thing. One of the big barriers we have for anything is having clinician adoption. When I look at digital health products or anything that's artificial intelligence based, I am a strong advocate. If a clinician is not involved or they're not part of that process and they don't believe in it, it's not going to fly. It's not going to work in the marketplace. The other thing is data access and privacy, and this is where I still feel we have a significant issue in healthcare. We work in data silos. There's not a clean, nice data set that you can pop into and just take and create a solution for. So there's lots of problems to solve. And we've heard about problems. I mean, great use cases being demonstrated, and they can work within that practice perhaps, or within that data set that you have. How do you extrapolate that to really drive something bigger or more impactful? And I'm a big believer that data privacy is a debate that still is really important to be had. We track general population attitudes and trends, and the biggest concern everybody has around data is about privacy and ownership. I advocate that we all as individuals should own our data. I should know what my data is being used for. I personally believe that. And I think this is a movement. If we think about generations, the upcoming generation, Gen Z, the alphas, who are very small right now, but very tech savvy, are going to want to have that happen. They're very clever. I did a really interesting study with a young group about healthcare, and they're already using pseudo emails, pseudo profiles online because they know that their data is being misused. That's interesting. How are we going to drive trust? Question we must ask ourselves. How are we going to drive trust into the use of data? Because only then we can combat the issue of bias. We have a huge bias issue around how we look at disease, how we don't recognize gender differences, ethnicity differences within data. We use one benchmark for all, and that's not necessarily right. A beautiful future using AI is predictive and personalized. But for it to be personalized, we need the right data sets to kind of make that happen. I always think about regulation too. The big pain in my life, regulation. It exists, it's a fact. Compliance and being responsible, of course, matters. And GDPR has done a lot to kind of drive data access and data privacy. But I think we can look at financial services as a model. I always go to fintech because banking and money has done it. So surely we can do it in healthcare. I mean, imagine if you could only use your bank card at the area where your bank exists. I could only go to that one bank each time. I couldn't use all the different ones. Imagine if I had to go to the bank to access my own money, that I didn't just have that information available to me readily. So I think we need to think the same way about healthcare. Healthcare should be available to us as individuals. It's my health data. I think we're starting to see movements towards that. I won't be unfair. I'm saying we're starting to see movements towards that, but more has to happen. So infrastructure for AI to be realized is really, really important. And then moving to patients, I think I have the wonderful privilege of speaking to many patients for testing new concepts and understanding what they think about this new idea that's coming to market. A recent study that I did was in oncology. It was a range of different cancers, and we were speaking to patients to understand, could there be a technology solution that could help them in their journey, in a very difficult journey that they go through? And what was really interesting was the big message that came out was they want more support outside of their consultation. They value the relationship with their doctor, of course, but there's lots of stuff that happens outside of that. The majority of health happens outside of a health system. So how could we potentially use artificial intelligence technology in a more supportive way across the patient journey? There were particular moments that came out that really struck. The first one was the actual role of the diagnosis. Being diagnosed with a health condition is difficult. It's a lot of information that you have to take in and understand. And I've got a quote here from one of the patients. At one point, you just stop listening. You can't absorb it all. Wouldn't it be wonderful if there was a way to capture that consultation, that transcription that the clinician desires to, the patient desires on their side, so they have an accurate record of what they should be doing and accurate resources that they should be pivoted towards. Mental health. something, of course, matters to me as someone I've trained in. But when mental health burden is significant for all of us, not just people who have a diagnosis, but how could we leverage more support tools around the patient journey? And I have to say, out of all the therapy areas, mental health has had some fantastic apps and solutions that are available in the marketplace that are driven by AI. So whether it's mindfulness treatments, short-term cognitive behavioral therapy treatments, or sleep-based ones, there's lots of fantastic tools available. And the other thing was that information at different times. I think Mike alluded to the 24/7 thing, and that is a huge benefit. One patient mentioned a chatbot. Wouldn't it be wonderful when I'm up late at night, stressed, and I've got a question, but I can't access the nurse, and I have to trawl through forums? Wouldn't it be great if I could just go to a chatbot and find out the answer to something which is quite simple, which is only when chatbots work, when they triage to a simple enough answer. And support. I think online gets a bashing, but it has done a lot in terms of giving people support and forums and making them feel normal, normalizing difficulties in diagnosis and helping them understand how to navigate. So I think there's a lot there in terms of that, but we do have an issue of confidence of use. Tech equity has been discussed on the panel. We have an aging population. We have to acknowledge that. So maybe that's where the smart home revolution could play more of a role, particularly, but it has to be frictionless. It has to be super easy, all the way to the upcoming generations who are absolutely going to be wanting more sophisticated solutions from us. So I think it's really interesting, the challenge that we have ahead. But I'll wrap up there and pass back to Fraser.
Thank you, Reena. That was brilliant. I love the breadth of what you managed to cover in 10 minutes. Clinician acceptance and acceptability, data availability, the potential of baking inequalities in, which a few people have mentioned in the chat box, and regulation. I was really struck by your reflections on patients and the way in which we might be able to harness the power of AIs to provide support outside of consultations. And the image you were conjuring for me of, I'm just going to keep saying Alexa just for the sake of setting people's Alexas off, but things like Alexa perhaps acting as health coaches. Maybe I think you were even hinting perhaps straying into things like, could they provide therapeutic interventions in mental health type arenas? I mean, there is a sort of fascinating set of horizons that open up when you consider things in that way. So I loved hearing from you. What I want to do is just to just to hear sort of final brief thoughts from all four of you, really, because what I've really enjoyed about listening to each of you is that you've picked up things that the others have said. Andy, can I come back to you first? Are there questions that have been raised by Mike or Farzana or Reena that have tripped thoughts for you?
I think that there are two really interesting points that were made. One about Reena's point there about algorithms traveling, and this is something that we've had where you build algorithms or data sets and predictive models on one data set, and are they applicable? Even the differences between the wonderful and lovely Hackney and obviously the terrible Newham, which is just down the road from us, and God forbid, even though I grew up in Newham, but it's but this idea of, even though two communities very, very close by to each other, where it's a 2-3 mile trip from Hackney to Newham, even if that, but we have very, very different communities, but also very different access to data. And there's some wonderful integrated data sets around Tower Hamlets. Again, I'm not saying that's Newham, but they have integrated data sets there that allow us to be able to understand a lot. So those algorithms created just next door may not be applicable to the data sets that you have available. But of course, your analysts know this, and of course, if you have open and transparent processes and how you built them, that makes an opportunity for you to be able to tailor it for your own needs. But also, a part of the work that Farzana and Mike was talking about around this personalization of healthcare and how we can better understand using this data to be able to try and choose the right technology. And again, as Reena mentioned, the kind of the behavioral insights that we have that allow us to be able to change personal behaviors. Because as Farzana mentioned in her talk, us addressing these social and wider determinants is incredibly important. One of the biggest drivers is our personal behaviours as well as our social circumstances. So understanding that and being able to influence that is a really big deal. I think a great opportunity for us if we do it the right way.
That's nice. I like the one thing I like in this area is the sense that when we're thinking about individual level behaviour change, we have all sorts of incentives and flaws and all the rest of it that cause ourselves to lie to ourselves about how we are. Well, the AI doesn't care in a sense. It's not so bothered about the, your sort of self-delusions and your own self-image. It will kind of presumably just record things and tell things as they are.
Well, just on that point, Fraser, as you know, when we look at predictive models, we know that the algorithms outperform healthcare professionals every single time. And again, those biases that you put in place, show that the algorithms can work.
That's quite a challenging segue into Farzana's thoughts. Farzana, were there things that others have said that you would like to comment on or pick up?
Yes, it's all been so interesting. I think Reena's some of Reena's points are really resonating. So Reena mentioned trust, trust in AI. So we know that nurses are the most trusted of all professions, and doctors come just under them, but doctors, healthcare professionals are very trusted, and I think it's about how we build trust with the AI, and particularly, as Reena was saying, around concern over, is my data private? Because actually that confidentiality aspect that we have in healthcare is something that we put so much emphasis on, and that leads to trust, doesn't it? I think the other thing that struck was, now I'm 48, I'm generation old, so I'm still quite keen on, I like seeing people face to face. I've missed that during the pandemic. My son, who's 18 and just gone to university, texts me even if he's in the next door room. I mean, that's not now. He prefers to text. And I asked him a few years ago, luckily he doesn't have any health problems. And I said, would you prefer to see your GP, phone your GP, or text your GP, or you're not online? And there was no hesitation. It would be online. Why would he waste his time speaking to someone when he can have? So something about the generation and the expectations, and what Reena was saying about, what we don't provide in a consultation, because the good old days are always the good old days. Nobody ever talks about the bad old days. And something that struck me during the pandemic is, because we've had a lot more online, and certainly in my practice, a lot more online, a lot of that information is written. And so what we're texting patients through the Accurex system. So I can say, I can see that you've got your blood test show you've got diabetes. We're going to do 1, 2, 3, and then come in. And I think that's been really helpful, because as Reena says, it's quite a life-changing thing. I've got diabetes in my family. My mum had it. I haven't got it yet, but I'm dreading the day I get it. And for me, it will be like, oh, I'm really old now, I'm that bit closer to the grave. That's what I will hear when somebody says, so I won't be listening to, and you need your metformin, and we're going to take you to the education centre, and you can do this. I just won't be listening. I'll be like, I'm really old now, aren't I? So I think that doing a consultation over time, which AI can do, and giving information that you can have when you want it, rather than 9 o'clock on a Monday morning, get yourself in there to see Farzana, and if you're 10 minutes late, we're going to say rebook. That's a system that isn't that great. So I think we can have both, have the creativity of the human mind, and have a lot of the other things that AI offers.
I just want you to, can you develop that point a little bit for me, please? There was something you said that I thought was really striking in your sort of introductory bit, where you talked about something sacred in the relationship between GP and patient. And in the relationship between GP and patient, that's in fact is chatbot and patient, or is patient texting and GP texting back, something is lost, isn't it? What's lost? What is that? The thing you were saying that is sacred between the GP and the patient, what is that you wouldn't want to lose?
So I think that is back to the trust and the relationship. So I have no difficulty now texting or responding online to pages that I know. But people that I don't know, people that are new registration patients, people I've never met before, I will pick up the phone or do a video consultation, not because they medically need it, but because I want it. And there is something about actually Fraser talking to me now where he is nodding and listening and giving me 100% attention, or if Fraser was just wincing a little bit and I think, has he got pain? Is there something on his mind that I would just lose in the written communication? And true story, one of my successes over 20, I don't have many, but I managed to diagnose appendicitis over the phone. Somebody told me he had back pain, and he had chronic back pain. There was nothing new, but as he was speaking, he caught his breath, and I knew my patient. I'd seen him for another long-term condition, and I said, I want you to come in because there's something not right and I don't know what it is. And that was just in that intonation of how he caught his breath, but it's because I knew him, and I would have missed that online.
That's a beautiful example. Reena, I for whatever reason, I've marked you as our sort of high point optimist on some of this stuff. I'm going to put that example to you in a moment. I'll just give you 2 seconds to think though, because I'll ask Mike, first of all, just to respond. And Mike, perhaps when you do, many of the questions in the chat, Clem, Becky, others, have been focused in on the aspect of inequalities that is about access. And that's to say, not everyone has decent Wi-Fi. I mean, many of us started lockdown with terrible Wi-Fi, but not, some of us don't have devices, some of us don't have access to phones even. I'd just like you to perhaps speak to that, because I remember you giving an example. I think you were talking about a sort of cohort of people who are homeless, who you were saying actually this was benefiting. So if you would just sort of respond to that topic as well as
I think one of my reflections around the sort of access and equalities agenda, and particularly I know Becky's point around internet and Wi-Fi and affordability of technologies. I've had many a conversation now with NHSX where we're often being told to look at remote monitoring, better sharing of information, and I keep pushing back. For some of us in the rural areas, you keep missing out this issue of connectivity. The assumption that everywhere has got good connectivity is a false one, and this needs to be considered, particularly from the health inequalities angle. Now, we ourselves in Hereford and Worcester are part of a 5G pilot that is trying to give a wider ubiquitous coverage in a couple of communities to demonstrate the social and economic worth of improved connectivity. And I think one of our rationales being that not every, in particular, not every full broadband, but maybe it's easier to provide devices, mobile devices, to many of those households if we had better connectivity. So that's one way of responding. The other way we're looking at it, could practices or libraries prescribe certain technologies like a device? Because are we talking about in the end using wearables and so forth? Should we, and apps, should we prescribe, we talk about social prescribing? Is that something we should consider as well as a response? And the other thing that we're thinking, I've talked to a lot of rural areas but there are ways in rural areas that if a village hall had a sort of a pod, a remote consultation pod, actually that would save potentially someone from Herefordshire travelling all the way up to Birmingham for their consultation appointment. So actually that's decentralising healthcare and bringing it more to rural areas and saving people journeys. So there are challenges there around inequalities, but I think it has the potential to really make healthcare more accessible. And I also would say, some people say about the digital literacy. I mean, some of the Ofcom statistics is that, 80% of over 65s now are using the internet. Maybe the skills are variable, but that's only going to increase as that demographic change. But we mustn't obviously forget about that 20%.
Thank you. We've talked, haven't we, here about economic divides. There have been some comments in the chat box about gender divides and ethnicity divides in data. But you've really nicely, I think, introduced the sort of rural-urban divide as well, and of sort of physical access, and how AI and digital tech might address some of those. I must say, you're all being too sunny. No one's being nearly gloomy enough about the potential of downsides of AI. Reena, I said I'd ask you the sort of what I'm now going to call the Farzana question, which is there is something in that relationship, isn't there, that is special, that is human, that is intuitive, which is hard to see, which is hard to make explicit. Amanda in the chat box says she got engaged with e-consult, felt like it was asking the wrong questions. Well, in human interaction, we can maneuver that, can't we? We know how to deal with that. It's very hard with the chatbot. What am I asking you to do? I'm trying to get you to defend the rosy picture that you painted of potential, chatbots and AI supporting people outside of consultations. Can you take some of those downsides for me and respond to that?
Yeah, definitely. Look, I'm a huge believer of the human touch and the mind and obviously the education and background that clinicians come with, right? That's the whole point. What we need to do is we need to do better in allowing clinicians like Farzana to do what they do best. You gave a wonderful illustration of how some of her time spent. It shouldn't be spent that way. And what we measure, I think, needs a look, because what you measure drives behavioral patterns on the ground. So currently, payment models, forms that we have to fill in, clips and we have to do certain things for whatever reason, as it is, it's kind of mandated that we need these data sets to come in. Wouldn't it be wonderful if the mandate was longevity of health, not disease? We live in a disease state, so everything's funded based on disease. Actually, no, let's think differently. That's hugely difficult to do, hugely difficult to do. I don't know if it's possible. But for me, when I gave the fintech example earlier, what did banking lose? They lost the personal touch. The bank manager used to know the family. There used to be a loyalty. And what I love watching is adverts from banks, because they play up this personal relationship that doesn't exist. The one of the teddy bear being left on the bus and the lady knew where they lived. I mean, that's nuts. No one knows that anymore. So they're playing up on personal, but they don't have that relationship anymore. We don't want to go down that road in healthcare. What we bring is the personal touch in health, but we need to increase the value. We need to make Farzana's son feel like there's a value to traveling for that visit. And at the moment, that value happens in private clinics. People pay a hell of a lot of money privately to have a consultation about longevity, where their genome is sequenced, where they have biometric data streaming in a slick little office like the Genius Bar of Apple. And then you kind of have a look at, okay, this is what your metabolic age is. These are the things you need to do to increase your longevity. This is happening in San Francisco. I mean, US is a private market. I mean, a lot of stuff that goes on. Again, it's incredible amount of health inequality, a terrible amount of health inequality in that country, which is fact based on the way the model is. We don't want to go down that road. We don't want to end up with this, if you're rich, you can do it, and therefore you get all this benefit of tech access and all this stuff, and then we have this huge inequity come in. So I want to see a future which is holistic health, collaborative health, where a patient and clinician sit down together and look at their health and think about it and contextualize it. And until that happens, that's when the value piece for the upcoming generation will exist for healthcare. Otherwise, we'll end up with a very transactional health system, which then, you'll end up with a divide. People will go on a chatbot, they'll go on a prescription service online because there's no other value of going in. And that's the risk.
That was very, very nicely put. And you're too subtle to resist my sort of crude goading about how terrible machines are and how they'll take the world over. So, look, thank you ever so much. You've also brought up a point. It's a shame we have 2 minutes left. You've also brought up a point which I would have just loved to explore, and maybe we will in a future session. Here we've been speaking as though the NHS and the social care system has control of this and has control of what it adopts. And of course it doesn't, because there's a private market response, and as individuals we will be buying products that come out on a private market, and of course there will be inequities in that, and we should expect wealthier people to buy better and poorer people to either not have or to have worse. So you've raised a fantastic point, which is probably due a whole session of its own. The abiding theme I've heard all four of you talk about is to try to work out, and it will be a constant dance, won't it? But is to try to work out where the human element is needed and in fact is unique and in fact is required and is non-substitutable, and where technology in general, but AI in particular, can usefully substitute for some human labour which is going on, but which could easily be substituted out in order to preserve and make the most of what the human can do relative to what the machine can do. So I really enjoyed your different perspectives on that, the different takes on it, and I really enjoyed the way all four of you built upon each other's points and helped us to develop that picture out. So thank you ever so much. Thank you ever so much to Farzana and to Mike and to Andy and to Reena. I really enjoyed listening to you, and from the comments in the chat box, it seemed that other people did too. I just want to bring the session to a close now, but to bring it to a close by saying this is of course an opening. I mean, this is, you know, session one in a 2-week-long festival with just some fantastic sessions. So please, if you've not already registered for forthcoming sessions, please do. There'll be many more sessions of this type to come. So thank you on behalf of everyone to our speakers, and thank you everyone who's attended, and thank you for your engagement. Take care.